And I'm going to say, welcome to the May Pathway session. Now, I'm Paul Reinhardt. I'm the founder of the New Canaan Parent Support Group. Our support group meets weekly, every Thursday, 7 p.m. And we hold monthly pathway sessions like the one we're having this evening. We also are excited to say that we are going to have our 5th annual Addiction Awareness Vigil in New Canaan in person this year on Wednesday, September 1st. So we're looking forward to that. And now I'm just going to go ahead and introduce Greg Williams. Greg is managing director at Third Horizon Strategies, where he is an addiction health strategist and collaborator. Greg is a person in long-term recovery from addiction, and his career has been dedicated towards removing barriers to those struggling so that they can get access to quality health care and recovery supports. He is an award-winning filmmaker of feature-length documentaries, The Anonymous People, which I loved, and Generation Found, and has several other video projects in his resume, and we could probably spend a whole hour talking about all his video work, but we're not. Greg has a master's degree in addiction public policy from NYU and well over a decade of experience working with organizations and government agencies on solving addiction issues. And so, I can't help but also mention that Greg's latest project on the film side is Tipping the Pain Scale, and I'm sure he'll refer to that. And what we're going to do is start with, just Greg, if you would just give some opening remarks, a little introduction to your projects, especially the payment reform work, and then we'll just move it into Q&A. And so with that, thank you very much for being here. And I was hoping that both Rich and Maggie could join me in welcoming Greg Williams.
Nice to have you.
Thank you. Thank you for having me. It's good to be a part of this, and thank you for all the work that Paul, you do to educate, inspire, and bring solution to the conversation. I'll just give you a little background on myself. I am in recovery since I was 17. I got into recovery right outside the Danbury area in Newtown, and have lived in Danbury most of my recovery life. Moved around a little bit between Pennsylvania and Colorado, but kind of have always come back to the Connecticut community. And most of the last 10 to 15 years now, I've been very interested in issues around public policy, in particular, access to care and access to services for people struggling with addiction and their families. And I spent quite a bit of time, and I do spend quite a bit of time, like dedicated deep in the policy side and deep in the finance and clinical side, which I'll get to. I think where I always like to start is around we can't change policies, we can't change systems until we open people's hearts and humanizing this issue, which you do with the vigil, which people do with the recovery walks, what other folks are trying to do in Zoom support meetings all across this country. Opening the hearts to other people who've been touched by this and bringing solutions. I think there's a lot out there about the problem. Connecticut was heavily featured the last couple nights on HBO about the problem, but you watch that stuff and it's frustrating and angering and whatnot, but it doesn't give you any answers. It doesn't, how do we fix this? How do we solve this? What do we do? And so I've been really blessed to have partnered with a great editor and storyteller named Jeff Riley, who lives in Branford, Connecticut. And he's been my partner on a number of feature documentary work that we've done. So Paul mentioned one is the Anonymous People, and then Generation Found. We also did a concert film and a couple other things that are about awareness and education for the issue and humanizing the issue. We're super excited because after a couple of years of not producing anything, we've been working on a film called Tipping the Pain Scale around different advocates and different leaders from different levels of society, different layers of solving these issues, and we've been following them. We'd shot most of it before COVID, and then COVID threw a wrench in our best laid plans. But we've been working through it and figuring out a path to finishing the film, during COVID, and so we we're getting set to release it this fall. We're not quite sure yet the distribution pathway, but we're starting to have those conversations. Um, the film is really exciting. We were following the mayor of Boston, who's a person in recovery for a long time, and now he just became nominated Secretary of Labor for the Biden administration. So the story got super interesting on that front. We've been following a guy named Darren Waller, who's an NFL starting tight end for the Raiders, and he became a Pro Bowler last year, and he's probably one of the best tight ends in the NFL. And he's been talking about his recovery, and there's a really cool story in there about that. And then we have folks who are doing street outreach work in Kensington, Philadelphia, and spoken word artists who are working in schools on prevention. Um, we have a young state legislator out in Washington State who's passing laws around treatment access and funding around that kind of stuff. And so it's a really cool human story about just people like yourselves who are doing pretty sensational stuff to try to bring hope to a pretty dark issue and to a pretty dark place. And so hopefully we're going to be able to leverage that film for some conversations and for some education and really to cross over and open hearts. I mean, I think that's the core of it, is through the storytelling, people watch things like that have solution, people in action, people doing things to solve the problem, and their hearts open. And then by the end of it, usually, given Jeff's amazing ability to weave these stories together, they're asking, what can I do? What more can I do? What else can I do? And it's kind of those moments where you want organizations like yourselves and others to be there to catch people when they say that, because there's a lot of work to be done, and we need a lot of people to be asking that question. We need a lot more people to be asking that question. And so that's been the focus of a lot of that film work. And so we're super excited. I'm also working now on some other films too that will come out in 2022 and 2023. So there'll be a good constant beat of production. We found a nonprofit who's kind of supporting Jeff and myself to produce some more content. So we're super excited about continuing to bring solution oriented content forward over the coming years. And it's definitely where a big part of my passion lies, and where a big part of I believe the solution lies. Uh, and then to transition, Paul wanted me to talk a little bit about the work that I do with Third Horizon Strategies, and that's focused around payment reform, and why we do payment reform work. Um, and so it for me it really starts on a personal level. You all will appreciate this. When I landed at Danbury Hospital ER when I was 17 after a near fatal car accident, they told me I had to go to treatment, or I was going to go to jail. And I took the bait and I went to treatment. And my family was privileged, and we had health insurance. and we had benefits, out of network benefits at the time. And, the treatment center calls, my father about 3 days in and says, the insurance denied the treatment, and we got to send your son home. And, my dad was like, well, he's going to die. What do you mean they denied it? And, the treatment center, said, well, they're saying that it could be done as an outpatient. And, you know, to my father said, well, whatever I got to do, just let me know, and I'll deal with it on the back end. And so he was able to scrape together the funds and put up the funds for me to stay there. And I did well. I went to a halfway house after that, and, I had a lot of progress in the treatment center. And, it was a real turning point in my life, obviously, that treatment stay. And, um, so that's, I get out, and then I'm doing the deal. I'm working at a car wash and all those kinds of things in early recovery. And I say to my dad, like 6 months in, I said, hey, did you ever go fight the insurance company, for the treatment stay? And he's like, no, it's a lot of work. I got to file paperwork and get all the records and all of that stuff. And I said, well, you should fight, because it obviously worked. I'm doing better in my life, as a result, and they should have paid for it. Like, you had the health insurance. And so he's like, okay, okay. So he files all the paperwork, because I was an adolescent at the time. So I had to probably sign some papers. I like turned 18 to rehab. But anyways, he gets all the records, goes through the appeal process. 6 months later, at this point, I'm like a year in recovery. And, a couple months later, he gets the rejection letter in the mailbox, from the insurance company, that, he didn't fail enough outpatient stuff. And so there's a second level of appeal, and he files, that with a letter. And they bring him into the corporate boardroom in, like, Milford. Um, and he's sitting in that room with, like, doctors and nurses, and there's like 20 people in the boardroom of the insurance company. And he tells our story. I'm like a year and a half sober, and it's like, he walks out of that room. He's like, every single person in that room knew I was right. There wasn't a person in that room who knew I wasn't right. And, still 2 weeks later, he gets the rejection notice in the mailbox. And then, and at this time, we had to go through those three levels of appeal to get to the outside, party. And this was 2001. He appeals to the outside insurance commissioner, and we have, like, this independent body in Connecticut to review appeals. And, they review it and they overturn it, and there's a check in the mailbox a few weeks later. And so it took them, a year and a half, 2 years of fighting. And good thing in Connecticut we have that independent review. We actually have a whole office now organized, and you don't actually even have to go through three levels of appeal anymore. You can appeal it, right away to this independent board. But it's still a complicated process for families, and obviously appealing it after the fact doesn't doesn't do a lot of people a lot of good, when there's denials on the front end that are life and death denials. And, so, um, it was that kind of experience where it's just like, something's wrong here. Like, this doesn't make sense to me. Like, they're costing themselves more money. I got into recovery. I'm not in the ER anymore. I'm not crashing my car. I haven't been arrested. Like, it doesn't make sense, for our society to deny me care, deny people care, for this issue. And so I started asking these questions, and those questions led to, speaking at the state. And, speaking at the state kind of led me to other people in this advocacy movement. And they were trying to pass this law called parity. And that's when I started making the Anonymous People, was a little bit during that period, and the battle to pass parity. And after that, and then the Affordable Care Act expended parity. And so it's very different today than it was back then. But that happened out of good advocacy and strong advocacy, that passed those insurance laws that now, in most states, are really, really important, laws that require insurance companies to, to purchase inpatient, outpatient, and pharmacy for both in-network and out-of-network, and on par with any physical health condition. And so there's good protections now. Whether the insurance companies really follow it or not is left to some court cases. There was a big court case a year ago, against United Healthcare, around this issue, and they lost, and it was it's called the Witt decision, and it was a big case, and so anyways, I got very interested in these issues of health finance from a little bit of the perspective of forcing insurance companies to fund these things. But on the flip side, what's really intrigued me is around the economics of the inefficiencies of how we address this issue. Because to the insurance company's credit, or to their, at least on their side, right? They don't know what they're buying. They don't know what outcomes they're getting. So they don't know if it's any good. What the services that they're purchasing. It's very different than other areas of healthcare. The operators are very different from many other the areas of healthcare. So we we continue to do that, and then we the other element is the providers, in the space, don't really know, kind of what they aren't getting compensated appropriately, and then individuals and families like us don't feel like we have the right access to the right things. And so what we really have is like a multi-sector issue, where it's not really like any side of the equation's happy with the current system. It's almost like everybody thinks it's broken. But how do you get from broken to a little bit better, to a little bit better, to a much better system, right? And what's that pathway look like? And so, that's where a lot of my work has been focused, is how do you take a broken system at multi-sectors and then try to align it, and part of the challenge between the insurance companies, the treatment programs, and the individuals and families is the misaligned incentives. Give me 1 second. I'm sorry. 1 second.
Greg has 3 young kids, and his wife is working at the hospital extra late this evening.
Yeah, sorry about that. I'm back. All right. So misaligned incentives. And so what we've done over the last few years is put together an alliance between health insurance companies, health systems, and nonprofits, and stakeholder groups who can start to address these issues of kind of this multi-sector issue. And so in 2017, we brought folks together and kind of said to them, what can we do to solve this? And everybody said payment reform. Payment was the issue. Is if we change the way we buy these services, we can start to change the outcomes. And so essentially, we developed what they call an alternative payment model. So today's system, an individual goes to a treatment center, and the insurance company or the individual, pays the bill if they get out, and then they have to go back to that same treatment center. The insurance company pays the bill, and then if they have to go back, the insurance company, pays the bill, right? And that could happen 3 times in 1 year, and it could be really expensive. And part of it is like we're sending people to the same services and expecting different results. And there's no accountability on the treatment center side to try to elongate the care and support people. So how do you kind of flip that around and think about what we call an episode of care, or a continuum of care over the long term? And so in the payment model, we fund in a different way where the incentive is around value, not volume. And so there's a set price for once somebody's engaged in services, there's a set price. And then when they, if they have to go back or recycle, then, the system doesn't, the providers don't make more money that way. They make more money if the person stays well, and there's a net cost savings. So, if you think about somebody's medical loss ratio every year, and what that was before, the substance use treatment, and then what it was the year after, that's where the shared savings and that's where the value comes in. And so you kind of flip the incentive from the substance use treatment system to a more value orientation where, if they create wellness, if they create outcomes, they can get to a better end. And so that's the work that I'm doing now. There's a lot of mechanics, and I can happy to share like a white paper that gets into it. But at the end of the day, we're really excited. We have in Connecticut the new Vance system on Western Connecticut. So they have Norwalk, Danbury, New Milford, and Sharon, and then Anthem is the biggest payer in our communities. And so we have them working together to pilot a model with the other providers attached to it. So that way you can get primary care and substance use treatment together, and then kind of manage the hospital and those kind of elements of people's care. So it's really a matter of creating a continuum of care. And so that's, the work that we do. And it's, it's been painful to watch, families struggle with finding care, seeking care, figuring out what the right care is. When at the end of the day, it's the wrong system. I think if there's anything that might be memorable or worth taking away from this conversation is, substance use disorders are a chronic condition. They're not an infectious disease. They're not an acute condition. And so as a result of being a chronic condition, this idea of a spin dry in 28-day programs or 6-week outpatient programs is it's fraught on its face, because we're throwing an acute care model at what is a chronic disease. And so when you look at how we deal with diabetes and we approach diabetes, there's some acute needs that people with diabetes have, and we address those needs, but they stay connected to care, and they're managed and they're adjusted when things go off, and they're offered a number of pathways. So there's medication, there's fitness and nutrition, there's other mental well-being practices. There's this whole host of things that people with diabetes can deploy, and some of them are a combination. And so when we really think about taking the substance use disorder continuum of care to like the next level, it's really thinking much broader in the context of how do we start to match the nature of the condition with a systemic response, and from the healthcare system. And with that comes the notion of staying and following with people for years, not months and not weeks, and supporting people kind of before any disruption happens, or supporting after. And I think that's the goal of the system transformation work that I'm really interested in, and certainly would love to share any more details about that, or answer any kind of questions that you all have about some of that work. But it's great to connect, and thank you for having me, Paul.
No problem at all. And as I told you, I have 14 questions at least. So I will get started, and then Richard, Maggie, if they want to join in. But let's just talk about what you think. You mentioned the word episode of care and the continuum of care model. In a pilot, like maybe that New Vance and Anthem would do, what period of time would you be talking about? Is it 1 year?
Well, so it would be 1 year performance periods, 1 year kind of episodes. That's only not because it's the right way to do it. It's because that's how we annualize insurance premiums is on an annual basis. So when you get your
Mhm.
insurance plan, whether it be Medicaid or commercial insurance, we underwrite people for 1 year, which is problematic, but that's the way the system is, and there's only certain amounts of system transformation we can enact all at once. But working within the confines of that, it's actually a 3 to 5 year model, and a lot of the savings happen in the subsequent years. But yes, the price point and the effectiveness of each, the triggering of each person would happen kind of on an annual basis, and the bundle price point would be on an annual basis, but that would get tiered down over time.
Well, can you give an example of somebody that comes in, maybe it's a 23-year-old with alcohol and cannabis use disorder, total, at this point, pretty dysfunctional. There's some co-occurring. And could you just talk about in the subsequent years, are you also talking, or in subsequent months, right, is recovery coaching going to be the option or be an option, or is it more the primary care physician is the advocate and they may bring in a therapist but we're not there yet with recovery coaching.
Yeah, it's a combination. So if they present kind of acutely in an emergency department, if we play that particular scenario through,
Sure.
the idea is upon presentation, the individual would be, assessed, obviously stabilized for any emergent medical needs that they have. Um, but then they would be assertively engaged, perhaps by a peer coach in the emergency department, or a social worker, or whatever, staff is on. But to let them know, hey, we have this program. You get a care coordinator, you get a coach. We can assess you, figure out the right levels of care. In that situation, I'm sure they would recommend some level of intensive outpatient or inpatient services based on the person's condition, and see if they could get that individual to go to that level of care, to get stabilized, get assessed both on the mental health side and on the addiction side. And then they would the care coordinator and the coach, kind of, that's part of the what we call an addiction recovery medical home, would stay with that individual, and stay involved in their case. So once, if it's a 4 week program, once they're discharged from a 4 week program, if it's a 6 or 12 week outpatient program, they'd stay with them and then support them. um, the primary care component certainly would be an element of follow-up and engagement. Often it's not going to be the primary care doctor themselves. They may become, if the person is taking like a medication, the primary care doctor can become the prescriber of any of the mental health and substance use medications. But on the team, there will definitely be, psychiatry and really about team-based care. So you would see social workers, drug and alcohol counselors, psychiatry, primary care coordinator, coach. Like, there would be a team depending on the person's need at the time and whatnot. But yes, then they would stay with that person, navigate them and engage them. And so, uh, yeah, and then that would go over time. And if the person needed, more engagement or linkages to employment, transportation, housing, other social determinants of health, they would be able to help navigate the individual to those resources in the community, uh, and certainly the family as well.
Then the care coordinator is likely to be a social worker.
Yeah, it's going to roll out as different roles in different places. It might be an alcohol or drug counselor. It might be a social worker. Um, Part of it's because when you're navigating people through different levels of care, a lot of the peer recovery coaches don't have clinical training. And so
Right.
they don't really have the ability to do like clinical assessments, or navigate people through medication. And we sometimes deploy peers in those roles, and I cringe. Like, a peer is really supposed to kind of live with somebody on this level and not necessarily be monitoring their medication or their levels of care.
Right.
Much more like working on a social emotional level with somebody around with whatever they need vocationally. Whereas a social worker, a therapist, a drug and alcohol counselor, a psychologist is a little bit more of a power dynamic where they can kind of dictate somebody's treatment plan and say, hey, you need a little bit of this, you need a little bit of that. Most of them can't prescribe, so they'll work with a psychiatry or a primary care doctor who can prescribe. But it's navigating all of those things and all of those nuances. But that's why team-based care is the way to go, where they can have bigger caseloads individually, but then you're able to ensure that people are navigated appropriately.
Okay. Rich, did you have anything?
Well, I do. I'm just trying to figure out how to ask it in a manageable fashion. I guess what continues to sort of frustrate me is as I go through this process, just when I feel like there's some light at the end of the tunnel to get a workable system around addiction, I start to realize that, and as we're seeing currently all over the news, there's really just a mental health crisis in the country. Right? So part of me feels like, and I don't know what the numbers are, but I'd be willing to bet that if we had a functional system to deal with people's mental health, we'd have a lot less addiction. And or that addiction could more easily bolt on and be administered by a more functional system to deal with people's mental health. Right. And I mean, I don't have to go on and on. I don't think it's controversial. I mean, if you look at like the number of shootings and suicides, right, and other things, and at least for me, our journey was around, teenage, early 20s addiction, which was a function of, it's pretty clear to me, we had emotional and mental health issues that led to maladaptive coping mechanisms, which were the addiction, and now we're winding out of that. Now, we were fortunate in that I had resources. I was able to just go to psychiatrists and kind of like your dad, I'll pay today and I'll fight later, right? But give me the care for my kid and we'll figure out how to do that. And it still didn't end particularly quickly. And it still was a bit of a patchwork and a whole host of other things. So I guess, I want to applaud you for the work you're doing and doing it in a manageable fashion where you actually seem to be getting some results. But do you ever think about or consider how you could take these improvements and actually leverage them across the whole system of mental health, or does that just bring everything to a grinding halt and then there's no progress at all?
No, it's a really good question. I think we've separated the notion of mental health, from substance use systemically, especially in early childhood. Really just because of how we funded it, not because it should be.
Right.
And so it's all interconnected, and the underlying trauma, the underlying pain. I mean, that's a lot of what our film is really getting at is I mean, there's this intellectual term called the self-medication hypothesis, where the idea that a lot of addiction relates to individuals self-medicating untreated trauma or unhealed pain, and what have you. And so absolutely, I think that there's some level of nuance between certain mental health conditions and certain substance use disorders, but so often they are very commingled. Unfortunately, the financing systems are a little bit disjointed, but I think part of the work is how to address some of this stuff earlier. How do you give young people the outlets, the ability to talk? I think the one most important common thread between mental health and addiction, from a policy framework, is nearly 90% of them are pediatric onset illnesses, meaning they're all early onset illnesses. Doesn't mean that all adolescents get heavily addicted like I did, but 90% of all people who become addicted in their life started using as adolescents, and it's very similar for most mental health conditions for young people. And so, where the system that I think is really broken, and we address this a little bit in the film, is our educational system, and because this is the only, like, dealing, systemically, we've got a lot of work to do with families and a lot of um, turmoil within communities and poverty and things like that. But our educational system, I mean, we spend so much time, and I've seen firsthand now with my second grader on Zoom, teaching math and reading and science, and like we do all this stuff, and you would think that we'd be spending, half of the time on emotional development and growth and mental well-being and coping skills and how to deal with trauma and how to deal with pain and how to be grateful, and like all of these things that are just life stuff that we've kind of, for the last 50 years in this country or whatever, just expected that people would pick up independently. And then we've thrown all this technology at people to isolate people even further, and so yeah, I think there's a lot of work to be done. So I think there's a lot of work to be done in the health system for sure around responding to these conditions. But I think the most important systemic work that needs to be done, honestly, is upstream in schools, and how we give young people in middle school and high school the skills to not turn to substances, to not turn to these negative behaviors when certain mental health challenges and stress and other things happen in their lives, because they have no other outlets.
So I, oops, hello, good
Hey,
evening.
Maggie.
Hi, Greg, so good to see you. Paul, thank you so much. And I actually feel pretty privileged that this is such a small, intimate group that, like, because typically I wouldn't be saying anything. So I feel like this is an honor. Thank you so much, Greg. I really enjoyed the way that you really talked about everything from the very beginning. And I might have missed this, but did you say whether your dad ever won the case with the insurance? Did you say that?
Yeah, so the Connecticut Insurance Department overturned on the third level of appeal. They overturned the case, and yeah, the insurance company had to write a check. He
Nice.
then donated it to the treatment center, but it was the principle of the
Exactly.
act. It was about the principle.
Yeah. And so I'm looking forward to I can't wait to see Tip in the Pain Scale, because I love, all of the work that you do with your videos, and I use them in treatment centers all the time. And so some of I love the language that you use as you were describing all of this, and the pathways, and when you talked about looking at the insurance and how the insurance gets to make the decision as to whether you or I need outpatient versus inpatient. How does that even like make any sense, right? And so I work in the school, and I'm working with youth right now. And I just had a grandparent who actually called me up and said to me, the whole in network and out of network and all of that language that they have to try to navigate and figure out when they're there trying to find services so that their kid, as you just mentioned, right, in school has another option, so that they're not continuously going to drugs as opposed to finding ways to manage their school life. And she was saying how she called the insurance company, and the insurance company, I believe it was Blue Cross Blue Shield, and the insurance company was saying to her, first of all, it was out of network, and also the fact that it was Rich talked about the mental health side. So this particular student just came out of the hospital because she overtook some of her medication. So that was under mental health. But because they had just paid for that, she could not now do any outpatient because there was no more benefit left for her to do that. Meanwhile, every month, this insurance is still being paid. so, and it just gets to exactly what you were talking about that there, it's such a hardship, and it's just, and I don't really know, other than saying to grandma, well, call back and ask to talk again and ask this question and what to do, how to help. So I feel powerless in the sense that there she is looking to get services, and the insurance where she's paying for, month after month is saying that you just came out, you were inpatient, and so now they won't pay for her to do some outpatient care, which should be a step down. It should be from the hospital to a PHP or an IOP, mental health or something of the sort.
Yeah, it's so frustrating. I'm gonna put a website in the chat.
Okay.
Parity is personal.
Mhm.
It might be worth having her check out that website, because I mean, that on its surface, and obviously there's a lot of details there, on its surface, to me, is a parity violation.
Okay.
So you can't put annual caps on treatment services
Mhm.
that way. There's like, you might have, a deductible. She might have a deductible, and if she can't afford the deductible, that may be a situation. But for example, like cancer treatment, could be $400,000 for somebody one year. That the insurance company doesn't tell you, yeah, you reached your cap. We're not going to pay anymore for your chemo. It doesn't work like that.
Right.
And so parity by definition means that if you treat cancer that way, then you cannot treat mental health that way.
Correct.
So
Okay.
if you have the same rule for cancer treatment, like you hit $5,000 or you hit $10,000 in cancer treatment, we're not going to give you any more cancer treatment. If that's what you do, then fine, you can treat mental health that way. But if they treated people like that way, they would have picket lines in front of their insurance company building, because people would be up in arms that insurance companies are treating cancer patients that way. So anyways, I don't know
Okay.
the details, but I'm happy to kind of connect or whatnot. But that website has a lot of answers or ways to address insurance companies.
Okay.
Even mentioning the words parity violation is
Mhm.
often a great way to get moved up in the food chain, because a lot of
Okay.
times, sadly, these insurance companies are calling, and it's a 20-year-old graduate who's reading off a screen,
Mhm.
and they're supposed to read off their little algorithm, and until you raise the you raise, it's like trying to get a credit on your cable bill. Until you get loud with them, you don't get anywhere, right?
Right.
So we got to start dealing with health insurance companies like we do our utility companies.
Yes.
We got to get a little loud. You got to ask for the supervisor.
Yes.
But it's sad. It's sad that people have to do that work, because that's hard work, and it's technical, and they can talk circles around people, and
Right.
it's complicated. So the other resource in Connecticut is the Office of the Healthcare Advocate. So I'll just put that up there too, and they can help.
Okay.
We have that's a great office that Vicky Veltre started, and it's a state agency, and they can help people navigate parity violations or insurance denials. So this is a great office to refer people to in the state of Connecticut, and they've returned a lot of money to the state of Connecticut, because what happens is insurance companies deny, and we as taxpayers pick up the we're the payer of last resort. So
Mhm.
somebody goes into crisis and they end up in the ER, or they end up in a locked unit or something like that, and we all pay for that because the insurance company denied it so long. We end up being the payer of last resort. So the healthcare advocate office was started specifically around this issue to navigate people to find resources and help them appeal. And 50% of their appeals that they win or more are in the mental health and addiction space. So they're very successful in that regard.
Thank you.
So, Greg, remember how you said there's three tiers to trying to get a denied claim, reversed. And did you say that, what is the third tier that you can go directly to? Is it to this Office of Healthcare Advocate?
Yeah, so I think the law changed. I don't believe people have to go through three parties of appeal. I believe, and I'm not totally versed on this, but the healthcare advocate could tell us, or there's probably
Yeah.
a link on the website. I believe people can go to the independent review board immediately. They can kind of skip internal insurance company appeals that are run by the company itself in Connecticut now. I think that was a law that the state passed in terms of they started seeing what the healthcare advocate was doing. And then they said, well, if these insurance companies never overturn their appeals, then what's the point of making people appeal
Yeah.
internally in the company if they never overturn their original denial decisions? So we might as well just go to this independent body and have an independent body review these cases. So I think people don't need to go through the three levels anymore. But I'm not 100% sure on the specific mechanics. But that office is a great resource for people. Anybody struggling with an insurance claim on this issue or any issue, they'll work with you on any other physical health issue too.
Yeah, I did talk with the woman, I think, who's the head of it. They're nurses. They have nursing background, so they really understand the whole medical infrastructure or ecosystem. So you mentioned both diabetes and cancer. So there's no one disease that you could say, oh, this is the best disease that's similar to addiction, that's chronic to be looking at. But diabetes is chronic, and cancer, usually you say, someone's in remission. They never are 100% cured.
Yeah, I do. Bill White, who's a formidable researcher in this space, he uses the cancer comparison quite effectively, and I think the cancer comparison is a really good one from not the disease process of cancer, like not the actual pathology, but like the pathology of diabetes is probably a better disease process, like 1-to-1. But the treatment system, the treatment methodology of cancer around once we like the way we do screening, the way we do early intervention, the way that we do acute, really intense services for chemo and those treatments, and then the way that we follow people aggressively for 5 years until their risk factor in remission drops back to the general population. That kind of model that we throw at people who are cancer patients is probably a really good example. And then not to be really crass, but look, not all cancer patients survive. I mean, we're dealing with a very deadly illness in addiction and mental health. And so there's no panacea that's going to save every life and that we're going to be perfect, but we can get a whole lot better than what we're doing today. And so, yes, I think cancer from a care model perspective of what the future system should look like is actually a really good synonym to what we should be striving for.
What about five? You mentioned 5 years, and before we got started, I was talking about a 5-year continuum of care, and especially with certain groups like airline pilots, or lawyers, or professionals, or doctors even. So, are you a proponent that really that 5-year tracking makes a lot of sense?
Yeah, I mean, we don't have tremendous data on it, but the only data that we do, it's in the Surgeon General's report, is after 5 years, people in remission drop back to the general public risk factor. So my risk factor for onset of an acute substance use disorder is about 15%. So incrementally, I'm still a little bit higher at risk than the general population, but I'm almost right there. Like general population risk factor is about 10%. So So yeah, I mean, I think the 5 year really does have a data point associated with it. It makes sense, intellectually. It makes sense scientifically. It makes sense on a lot of levels. I think, you know, and especially with substance use, with certain mental health conditions, it's not the same. So schizophrenia, bipolar, um,
Yeah,
other co-occurring illnesses, somebody might need permanent support from the healthcare system, but people in remission from substance use often can kind of uh, drop back to the general population. That doesn't mean that year 6 and 7 the primary care doctor shouldn't be asking the person, how are you doing with
yeah,
your substance use recovery. It doesn't mean that when you go for surgery it shouldn't be part of your record that, hey, you had a substance use problem, and the surgeon should know that. It doesn't mean that like it's erased. It should still be part of your history, just as if you had a cancer biopsy 10 years ago and something else pops up 10 years later. Like, you want the physicians 10 years later to know what happened 10 years ago, right? So like, we want to make sure that healthcare practitioners are informed with that information, and then they understand what that information means. Because so often we see people in long-term remission of substance use, and surgeons don't care. The oral surgeons don't care. I mean, they're some of the worst dentistry and oral surgeons. They just still prescribe, and we see so many people who are just out. They were just alcohol use disorder, and they go in for oral surgery or back surgery, and they get hooked on the pills and the interrelationship of the substances. I mean, we don't do a good job there. So a lot of work to be done.
Rich, do you have anything else?
No, I tend to hand wring a little bit over some of these more macro issues that there probably aren't solutions to that are going to help move the needle anytime soon. Like I can't, politicizing this aside, I feel like so long as people with resources can continue to afford to pay for it out of their pocket, it's going to take a long time for this to change. Right? That's kind of the bottom line, and that's unfortunate. And then I guess the second thing I can't figure out is, given that people with this disease don't need the same type of, like, they don't need wound care, they don't need to be hooked up to machines. I don't think of them as incurring the same level of expenses as someone that has to stay in a hospital for inpatient, right? They certainly don't, I think, need the same nurse to patient ratio and all these other things, and the same level of medication. I, for the life of me, can't figure out why this can't be done in an economical fashion where the losses are shared across society like we do for everything else. But I see it, and I know that's real, right? And I'm not in the industry enough to know it, but it is something that when I have some free time, I kind of think about, because you would think that, frankly, that some people could make money on this, but what I'm seeing is there's a couple of more higher end centers, right, that can take a cash only model for service, and then you go collect from your insurance yourself, and then there's the whole rest of the world. And I would have thought that there's enough resources in the system to take care of this, but I guess, frankly, enough people are not costing the system enough in the consequences. And maybe that's the problem. When the system ultimately has to reconcile with this, it's when people die, right? There's not as much intermediate cost in the system that people recognize, like they might with diabetes or heart disease or other things, right? Like if somebody has diabetes, they could have a very expensive medical history over time, right? Between blindness and amputations and all these other things. And, one of those treatments probably costs more than an entire stay in rehab for somebody, right? Like if you have to have limbs amputated or things like that. Like I watched my uncle die from diabetes, right? It was very long and very, very expensive.
Yeah. Well, there's certainly some very high end expenses, but I will say, on the aggregate, because of the population of impact, people with addiction, and specifically opioid use disorder, are nearly 2, 3, 4x to 1 the average person. So if you compare person with substance use disorder to the average medical population, you get a really perverse distortion of the amount of spend on those individuals. If you compare high-end person with diabetes to high-end person with substance use disorder, you're probably right. Diabetes is probably a little bit more expensive in that person. But then there's a lot more people that drive those averages down with diabetes that get different care. So substance use is a spectrum illness. So we can't just think about part of the problem with our current system is that, you know, we can't just keep putting people in these treatment centers. So yeah, it's a good point. It's a really good point. The economics, I think, are really important. There's a cool podcast if you're really interested. My business partner does a podcast called Cost of Care, and he gets into all these macroeconomic issues in the healthcare system and why we can't get it right. So he talks a lot about addiction too. So it's good.
Part of this is almost perverse on my part. It's almost a desire that, boy, if there was a way for this to be profitable for enough people, it would get fixed, right? So if you could figure out how to make that happen, it would then get a lot more attention because you just follow the money. But that we just haven't quite figured out how to make that happen for the more people, right?
Yeah.
And this is your partner at Third Horizon, right? Right, Greg?
Yeah, David Smith has a podcast. It's free. You can get it. It's called Cost of Care.
Okay. I just, before we go, I was just curious about, I think it was an interview you did with William White. You mentioned this, it's, you know, when you think about it, you go, yeah, that probably is right. You said about 25% of college students would, you know, qualify as having a substance use disorder if you look at DSM or, you know, diagnostic criteria. And you would say that today as well?
Yeah, I mean, I think that, yeah, most, you know, you get a lot of binge drinking and a lot of substance use. It's an early onset illness. So yeah, you see most of the data skews under 25 and, you know, it's skewing a little bit to 35 to 45. But, you know, it's 45 and under. I mean, the 20 million people impacted by and large, there's definitely a proportion that are over 45, but by and large, this issue is, you know, 12 to 45 and probably on the younger side of this in terms of the most prevalent impact over the population.
Right.
What's
And that's
the,
why,
what, I'm sorry, Paul, what's the time lag that it takes to get those numbers? Is that just based on like admissions or is it on deaths or both? Because I'm curious how long it's going to take for the pandemic to ripple through. I'm sure the numbers are going to increase dramatically over this time, right?
Yeah, I mean, we get the overdose. I mean, we have bad data in this country. We get lagged. It's, you know, so the CDC does the overdose and death data. I think the study that most people quote that does the annual, it's a household survey called NISDA, National Survey of Drug Use and Health. And that's the survey that does it. They do it every year. So we'll get some numbers in September released for 2020. We'll see what that is. And then certainly we'll get some numbers in 2022 that talk about what 2021 is for sure. It'll be interesting to look at. But we've been doing that survey for decades. So you're able to do a longitudinal analysis, which will give us a nice textured and concrete numbers to whether there was a bump, whether there was a spike or anything.
yeah. Well, Greg, this has been very informative. I really appreciate you taking the time and sharing your insights. And maybe we'll do another pathway session after pain scale comes out, and you can talk about that as well. But this was really helpful. And I just want to, with Maggie and Rich here, just thank you and give you a round of applause.
Thank you.
Thank you
Thank
so
you
much.
all.
So good to see you, Greg.
Yeah,
Good to see you too. Have a good night.
All
Yep.
right.
Yeah, I like
Sure.
anonymous people
With the
and,
kids and the work. Good job.
yeah, I like